Hello, everyone, and welcome. Thank you for being a part of WebMD's webinar today, where we will explain why breast density matters. My name is Taryn Kanza, and I'm your host. At WebMD, we provide you with up-to-date medical news and information you can trust. Today, you'll learn about breast density and why it matters. You'll also discover how to find out what your breast density is, why knowing that is important, and how it might affect your risk for breast cancer. In addition, Elizabeth Dibble, MD, will go over the role of imaging in breast cancer diagnosis and treatment. She's a diagnostic radiology specialist and associate professor of diagnostic imaging at the Warren Alpert Medical School of Brown University. And after the presentation, she'll answer as many questions as possible from you, our viewers. So please type any that you have in the panel on the right of your screen, and we'll get to as many as possible. And please note that we can't answer any questions asking for personal medical advice. This webinar is intended for informational purposes only and does not substitute for professional medical advice, diagnosis, or treatment. Always consult with your physician or care team about your medical care. And for your convenience, this program is being recorded, and a link to the recording will be emailed to you after the webinar. So now I'm going to hand it over to Dr. Dibble.
Thank you so much, Taryn. I'm very happy to be here with you all today to talk about breast density and why it matters. Just to give you all a little bit of an overview of what we're going to be talking about, we're going to start by answering the question, what are dense breasts? Then we're going to talk about how breast density affects your cancer risk. Then we'll go over some tools that you can use to understand your breast cancer risk. And then we're going to go through all of the additional screening options that are available above and beyond your standard mammogram. So first, what are dense breasts? Breast density is something that's determined by imaging. Specifically, this is something that we can see on a mammogram. So if you look at these images on the right of the screen, what you can hopefully see is that the breast here that we're showing a mammogram of that's labeled dense looks mostly white, as opposed to the breast on the far right side of the screen, which looks mostly dark, and that's a fatty breast. So dense breast tissue is a normal finding. Almost half of women have dense breast tissue. About 45% of all women have dense breast tissue, and 3/4 of women under the age of 50 have dense breast tissue, and more than 1/3 of women over the age of 50 have dense breast tissue. So breast density tends to decrease as women get older, especially after women go through menopause, but plenty of women who are premenopausal have non-dense breast tissue, and plenty of women who are postmenopausal have dense breast tissue. And all that we're really seeing here on the mammogram is the ratio of the dense fibroglandular breast tissue to the fatty tissue in the breast. That fatty tissue, again, looks dark, and that dense fibroglandular tissue looks white on the mammogram. And the reason why this all matters is because mammograms are less accurate in dense breasts. So we're going to take a little bit of a deeper dive here, and I'm going to show you how breast density is actually on a spectrum ranging all the way from very, very fatty breast tissue to very, very fibroglandular dense breast tissue. But we in radiology put mammograms into one of 4 categories in our mammogram reports, ranging from the least dense to the most dense type of breast tissue. And so again, looking at these images, on the left-hand side of the screen, the least dense type of mammogram we label almost entirely fatty. Then the next category is labeled scattered areas of fibroglandular density. The next category is heterogeneously dense breast tissue, and the most dense category is extremely dense breast tissue. So the first 2 categories on the left of the screen here labeled not dense, those are not considered to be dense breasts. But the heterogeneously dense and extremely dense breast tissue on the right-hand side of the screen, those are considered to be dense breasts. So when you get your mammogram report and when your doctor gets your mammogram report, you will actually have one of these categories in your mammogram report that explains to you what your breast density is. And so now I'm going to show you a phenomenon that we call masking. So look at the not dense mammogram. And what I just popped up there is a little spiculated mass that looks sort of what like a cancer might look like on a mammogram. And what I hope you can notice, I'm going to put some red circles around those so you can see them a little bit better, because I have a lot of practice looking at these, but I know you all don't. So there's the red circles showing that little spiculated mass on the mammograms of patients who do not have dense breast tissue. And what I hope you can kind of recognize is that you can see that pretty well compared to the darker fatty tissue on the non-dense mammogram. So the cancers tend to be sort of a similar color and density to the denser breast tissue. So now contrast this with the dense mammogram images. I'm going to show you what a cancer might look like on those mammograms. Run on 1, 2, 3. There it is popping up on those mammograms. And what I hope you can recognize is that it's a lot trickier to see that because the cancer is really, again, a similar kind of color to the denser fibroglandular breast tissue on those mammograms. So next we're going to talk about how breast density affects your cancer risk. So dense breasts are linked to an increased risk of breast cancer, independent from the masking phenomenon. It's also linked to patients presenting with larger and more aggressive tumors at the time of diagnosis. And it also is associated with cancer already being present in nearby lymph nodes at the time of diagnosis of breast cancer. And this is something that we call node-positive disease. In an effort to improve public awareness of the limitations of mammograms in imaging women with dense breast tissue, specifically the fact that mammograms can miss cancers in women who have dense breast tissue, 38 states since 2009 have enacted breast density notification laws. And most of these laws require facilities that perform mammograms, like your imaging centers and your hospitals, to inform women of their breast density, and usually also to inform women of the possible benefit of added types of screening. There's also a federal dense breast notification law that was signed in 2019, and that law directed the FDA to develop breast density reporting language and ensure that patients and providers would receive information about their breast density, including information about masking, which again decreases the accuracy of the mammogram, and about their qualitative breast density, which are those 4 categories that I mentioned. And then a reminder for people to talk to their providers, meaning their doctors or their non-physician providers, about any questions or concerns they have about their breast density. So that law, again, was signed in 2019, but it wasn't until March of this year that the FDA actually developed the language and issued their national requirement for dense breast notification. And this rule doesn't go into effect until September 10th of 2024. So mammography facilities or places that give you your mammogram have to comply with this new federal notification law in September of 2024. So just about a year from now, everybody will have to comply with this federal notification law. So this requirement issued by the FDA was a 46-page document, a long document. And what's relevant here for all of you is that patients are going to now be required to be notified about whether they have not dense breast tissue, non-dense breast tissue, or dense breast tissue. And if you do not have dense breast tissue, this is what you're going to get in a letter. So it says breast tissue can be either dense or not dense. Dense tissue makes it harder to find cancer on a mammogram, and it also raises the risk of developing breast cancer. Your breast tissue is not dense. Talk to your healthcare provider about breast density, risks for breast cancer in your individual situation. So that's the information you get after your mammogram if you do not have dense breast tissue. Now, on the other hand, if you do have dense breast tissue, here's the information you're going to get. So it starts off the same. Breast tissue can be either dense or non-dense. Dense tissue makes it harder to find breast cancer on a mammogram and also raises the risk of developing breast cancer. Your breast tissue is dense. In some people with dense tissue, other imaging tests in addition to a mammogram may help find cancers. Talk to your healthcare provider about breast density, risks for breast cancer, and your individual situation. So again, this is going into effect in just about a year from now. This national requirement also rules that providers have to be given an assessment of your breast density. So again, which one of these 4 breast density categories your breasts fall into. And I thought you might also find it interesting to know that there's another bill in Congress called the Find It Early Act, HR 3086, which was introduced by Representative Rosa DeLauro of Connecticut. And this bill calls for health coverage with no cost sharing to patients for additional breast screenings for certain individuals at greater risk for breast cancer. So you might recall that the Affordable Care Act called for mammograms, screening mammograms, to be covered in full with no cost sharing. So your screening mammogram should be free of charge to you, meaning no copay, no deductible. And this act that's currently in Congress, the goal of it is to do that for other types of breast cancer screening, to make sure that patients are responsible for what sometimes can be hefty copays and deductibles, even when their insurance does cover exams. And of note, 28 states right now do currently mandate some insurance coverage for supplemental screening like this, but that does not mean no cost sharing for patients. So next, we're going to delve into tools that you can use to understand your breast cancer risk. So what I want to first explain are that we kind of think about 3 levels of risk for breast cancer. What we consider to be average risk for breast cancer is a less than 15% lifetime risk of developing breast cancer for you as a patient. And that number comes from the fact that 1 in 8 women will be diagnosed with breast cancer in her lifetime. So that's a 12% risk for all women. And what we consider to be intermediate risk is 15 to 20% lifetime risk of breast cancer. And then what we define as high risk is a 20% or greater lifetime risk of breast cancer. So you might be wondering, how do we figure out which one of these numbers or which one of these categories you fall into? And I'll get to that in just a moment. And a lot of people, I'll argue, don't know their breast cancer risk level. So there's a new guideline that was issued just this year from the National Comprehensive Cancer Network. And they say that individuals should undergo breast cancer risk assessment by the age of 25, by 25 years old, and be counseled regarding potential benefits, risks, and limitations of breast screening in the context of their risk stratification. So again, we need everybody to be risk stratified by the age of 25 years. So this is sort of a new paradigm that everybody's working to sort of figure out how we're going to screen all of these people to give them their risk level for breast cancer. So now I'm going to talk to you about some of the factors that can increase your breast cancer risk. Well, the most kind of common factors are just being a woman, and by that, throughout this talk, I mean a cisgender woman or an individual who's assigned female at birth. And also just getting older will increase your risk of breast cancer. But there are a lot of other risk factors as well, including genetic mutations that can increase your risk for breast cancer, a family history of breast cancer, body mass index, race and ethnicity, with Black women and Ashkenazi Jewish women at specifically higher risk. History of benign breast biopsy can very slightly increase your risk as far as we can tell from the current data. Any history, personal history of atypia on a biopsy, which is abnormal cells, or LCIS, which stands for lobular carcinoma in situ, those increase your risk of breast cancer, as well as things like when you got your first period, how old you were when you gave birth to your first child, and what age you were when you went through menopause all factor into breast cancer risk. If you have a personal history of radiation therapy to your neck, chest, or armpit area in the past, or any exposure to DES, which is a synthetic form of estrogen that used to be used more commonly. So putting all of those risk factors together, there are several models that we use to calculate your personal risk of breast cancer. And there's a very common simple model called the Gale model that takes into account your current age when you first got your period, the birth of your age at the birth of your first child, whether you have any relatives with breast cancer, any prior breast biopsies, and your race and ethnicity. And there's another very common model that takes all of those things into account, plus some additional things like body mass index, your current menopausal status, whether you have a history of hormone replacement therapy, whether you have a known BRCA1 or BRCA2 gene mutation, personal history of ovarian cancer, Ashkenazi Jewish ancestry, and importantly, your breast density. So that's a very, very common model that we use a lot when we're trying to kind of risk stratify people. And what I'm showing you here is that you can do this yourself. I put Tyrer-Cuzick into Google and it pops up a couple of websites where you can click on the website and put in your personal history and figure out what your risk is for developing breast cancer. So I clicked here on this Iconopedia IBIS test, and this is the website that pops up. And again, it asks you just a whole bunch of questions, including what's your age, what's your weight, and all of those other questions that I talk about. And at the end of the assessment, it'll spit out your personal risk of breast cancer. So that's something that everybody can do if they want to just have some idea about where they fall with regards to that average, intermediate, or high risk for breast cancer category. There also are more than 20 other models for calculating breast cancer risk, but like I mentioned, that Tyrer-Cuzick is one of the most common ones, and it does take into account breast density, and not all of the other ones do. If you're interested in learning more about that, here's a paper that goes through all of those models and sort of explains the different risk factors that they take into account. So in addition to all those risk factors, I mentioned the BRCA1 and BRCA2 gene mutations that can increase your risk for breast cancer, but there are also 9 other genes and genetic syndromes that have been identified that also increase your risk for breast cancer. So sometimes people will say they had a relative tested 20 years ago for the BRCA gene, but I want everybody to understand that all of these genes weren't tested for 20 years ago. So we're identifying more and more all the time. And some of these genes, just so you have heard of them, include the gene ATM, which is associated with a syndrome called ataxia telangiectasia, the BARD1 gene, BRCA genes, as I mentioned, the CDH1 gene associated with a syndrome called hereditary diffuse gastric cancer, the CHEK2 gene, NF1 gene associated with neurofibromatosis type 1, PALB2 associated with Fanconi anemia, P10 associated with Cowden syndrome and Benayan-Riley-Ruvalcaba syndrome, STK11 associated with Peutz-Jeghers syndrome, and TP53 associated with Li-Fraumeni syndrome. So a lot of genes now that are known to increase an individual's risk of developing breast cancer. So next, you might wonder, so those are all the genes that are associated with breast cancer. How do I know if I need to undergo genetic testing? Well, the first thing to ask is whether you have a known breast cancer. So for example, if you were just diagnosed with breast cancer, when might your provider recommend genetic testing for you? And there are a few scenarios where they likely would recommend it. If you were a younger age when you were diagnosed with breast cancer, if you were diagnosed with a triple negative breast cancer, which is a subtype of cancer that has no hormone receptors and no HER2 receptors, if you've heard of that. If you've been diagnosed with a second breast cancer, if you have been diagnosed with breast cancer and are of Ashkenazi Jewish heritage, or if you have certain family health history, including a known relative with breast cancer at a young age, or a known male breast cancer in your family, or a family history of ovarian, pancreatic, or prostate cancer. But if you do not have any known personal breast cancer, then when might someone recommend genetic testing? That would be if you have a known family history of one of those gene mutations that's known to be associated with an increased risk of breast cancer. If you have no known breast cancer, but a personal history of ovarian or pancreatic cancer, if you're a male patient with breast cancer or pancreatic cancer, or high-grade or metastatic prostate cancer, then you might need genetic testing to evaluate your risk for breast cancer. If you have a family history of breast cancer diagnosed in a relative at a young age, or more than one family member with a history of breast cancer, or any male breast cancer. And if you have a family history of ovarian, pancreatic, or metastatic prostate cancer, those would all be reasons why your provider might recommend genetic testing for you to see if you carry one of those known genetic mutations that increases your risk for breast cancer. So that was a summary of the tools you can use to understand your breast cancer risk. Now I'm going to move into talking about additional screening options that you might consider depending on your risk level and your breast density. So before I jump into the first topic there, I just want to mention again that what we kind of consider routine screening throughout, the past 20, 30 years is a standard 2D mammogram. I'm going to go into 3D mammograms in just a moment, but just so you have some kind of background information about how many cancers we typically detect with this type of screening method, 2D mammograms usually detect about 2 to 7 cancers per 1,000 women that are screened. So that's 0.2 to 0.7% of all women will have a cancer detected on their mammogram when they come in for routine screening for breast cancer. So how does that compare to a 3D mammogram? Well, hopefully you've heard of a 3D mammogram. It's very similar to a 2D mammogram in terms of what your patient experience would be. You still come in for your regular mammogram every year, and the images are just acquired a little bit separately, where the X-ray beam, because mammograms use X-ray technology, comes over your breast in an arc shape and then goes to the computer system and gets reconstructed for us in radiology to view at little 1 millimeter slices through your breast. And what that does is it allows certain areas of the breast to sort of come into focus, which allows us to see things better, sometimes through the dense breast tissue. So I'm going to show you just a case of a 2D versus 3D mammogram. This was a 58-year-old woman who had a normal 2D mammogram where we saw heterogeneously dense breast tissue, but we didn't see any cancer on the 2D mammogram. I'm going to show you, this is what one of the slices from the 3D mammogram looks like, and what I admit that this is a subtle finding, and we go to school for a long time to find these subtle findings, but in the yellow circle is something we call architectural distortion, which means that the breast tissue is pulling a little bit to just a certain point on the mammogram. And this turned out to be an invasive ductal carcinoma that we could only see on the 3D mammogram. It was not visible on the 2D mammogram. So 3D mammograms now are really very, very widespread. It's almost not fair to consider them a supplemental screening option anymore because they're really becoming the standard of care. There was a large screening trial called the Oslo 3D mammogram screening trial that showed increased cancer detection for all breast densities in women who underwent a 3D mammogram compared to a 2D mammogram. And the 3D mammograms found about 1 to 3 additional breast cancers per 1,000 mammograms compared to the 2D mammogram. So remember, our range was about 2 to 7 for the 2D mammogram. So we find 1 to 3 more breast cancers on top of those that we found with the 2D mammogram. But a big limitation is that it's still hard to detect breast cancer in dense breasts, even on a 3D mammogram. So it really doesn't obviate the need for potentially undergoing some additional supplemental screening. So the big benefits of the 3D mammogram are that, like I said, it's just like a regular mammogram from kind of the patient perspective. And it's relatively inexpensive compared to some of the other methods that we're going to talk about next. But some of the limitations are that it's less accurate than other supplemental screening methods. And like I said, it's still harder to detect cancers in dense breast tissue, even with a 3D mammogram. So now we're going to talk about ultrasound imaging of the breast. So this is what an ultrasound machine looks like. So again, from the patient perspective, you'll have the little probe, just like when you're pregnant and you get a prenatal ultrasound. The probe will go on your skin, and we're able to use sound waves to visualize the breast tissue underneath the skin. But this is the machine and the type of image that we get to interpret. So here's another case example for you. This was a 59-year-old woman who, again, had heterogeneously dense breast tissue. So again, we can see a lot of that white tissue on the mammogram compared to that darker fatty tissue. And her mammogram was normal. She underwent additional or supplemental screening with a same-day breast ultrasound, where we look at both breasts completely using ultrasound, and we identified a 9mm invasive ductal carcinoma, so a small breast cancer in this patient that was not visible on her mammogram. So that would be the benefit of supplemental screening. So ultrasound can detect some cancers that mammograms can't, and it is the most widely studied kind of supplemental screening method that we have used for women who have dense breast tissue and want to undergo some kind of additional imaging. There was a large trial several years ago called the Akron 6666 trial, and that was the first large study of ultrasound in women who have dense breast tissue and at least one risk factor for breast cancer. And in this trial, the authors detected about 4 breast cancers, so 4 additional breast cancers on top of what we already found with the mammogram, in every 1,000 women screened. So a higher rate of cancer detection than women who just underwent a mammogram screening. Now we know in average risk women, so remember in that large first trial, women did have a risk factor for breast cancer, but in average risk women, we find about 2 to 4 additional breast cancers detected for every 1,000 screenings after a 2D mammogram. and 1 to 3 extra breast cancers detected for every 1,000 women screened after a 3D mammogram. So we find a little bit more cancers on the 3D mammogram, remember, than the 2D mammogram. So we find a little bit fewer extra cancers on the ultrasound after a woman has already undergone a 3D mammogram. But ultrasound has some big benefits. It's relatively inexpensive, again, compared to some of the screening methods that I'm going to talk about next. It's relatively comfortable for patients compared to some of the other methods. They're just kind of lying on a cot while the technologist scans over their skin with the probe. And it doesn't involve any radiation at all, so some people like that. But it does have some limitations. There's a relatively high false positive rate, meaning we find a lot of things that we have to either follow up with imaging or we have to do a biopsy before they turn out not to be cancer. And in addition, ultrasound does not appear to be as accurate as additional screening with MRI, molecular breast imaging, and contrast-enhanced mammograms, which are the 3 methods that I'm going to talk about next. So moving right along to MRI screening. So this is what an MRI machine looks like. Probably some of you have had an MRI or know someone who has had an MRI. It's kind of like a big donut hole, and people lie on this cot that's coming out of the hole and slide into we call it the magnet, to get their images taken. And sometimes these exams can take kind of a long time, but they're a really, really great way of seeing detailed anatomy, especially for soft tissue structures like the breast. So here's another case. This was a 49-year-old woman who had a known BRCA1 gene mutation. And what you might notice looking at these mammogram images are that this patient does not have dense breast tissue. So most of the mammogram is that darker fatty tissue. But she underwent supplemental screening with MRI because she had that known genetic mutation. So she underwent high-risk screening 6 months after her mammogram to do an interval screening every 6 months. And she was found to have a 4-centimeter suspicious lesion in her left breast that, I realize my yellow circle up here has moved, but in this area of the left breast on her MRI, and this area on the other view of the MRI. This is we call it our sagittal view and our axial view on the MRI. So this patient underwent an MRI guided biopsy of that suspicious area. And what we're seeing here in this inside of the yellow circle is that MRI guided needle biopsy with the tip of the needle right in that suspicious area. And we in radiology do these biopsies. And this patient was diagnosed with ductal carcinoma in situ that could only be seen on her MRI exam. It was completely occult or not able to be seen at all on her mammogram. So we know from years of research and data that MRI is the best screening method for women who are at high risk of breast cancer. And again, that's defined as a risk of breast cancer of greater than 20% over your lifetime, regardless of their breast density. And we know that it's more accurate or more sensitive than mammograms and ultrasound. And by this, I'm talking about a regular MRI. And I just put that in here because some of you may have heard about the technology called abbreviated MRI that's been kind of growing in awareness. And that's something that is used for women for supplemental screening in some areas of the country. So again, this is definitely a regular MRI, not the abbreviated MRI, is well validated as the best method for women who are at high risk for breast cancer. And they typically undergo an MRI every 6 months, alternating with a mammogram. So MRI, then 6 months later a mammogram, 6 months later an MRI. But for women who have dense breast tissue but are not at high risk for breast cancer, we also know that MRIs have an additional cancer detection rate of 10 to 20 cancers for every 1,000 women screened. So higher, definitely much higher than the additional cancer detection rate with 3D mammograms or ultrasound. And that's the number for when a woman undergoes her first MRI exam. And that's either with abbreviated MRI or a regular full MRI. That number comes down a little bit if you undergo MRIs every year, but it's still higher than what we see with 3D mammograms and ultrasound. And you usually will still need to undergo a mammogram. And typically, like I said, most women will alternate every 6 months. And if an MRI is performed, there's no need for other supplemental screening like with ultrasound. And interestingly, just in the past few months, the European Society of Breast Imaging has released a statement saying that providers should recommend supplemental screening for women with extremely dense breasts. So that's that most dense category of breast tissue, the 4th most dense category. And MRI is preferred based on currently available evidence. And what they say is that women should undergo an MRI at least every 4 years and preferably every 2 to 3 years. And then just last month, our American College of Radiology has also recommended that women with dense breast tissue should undergo MRI, but they say that women should undergo annual MRI. So this is a brand new recommendation. It hasn't been adopted by other specialty societies, but it's very interesting that we're sort of heading in this direction, it looks like. So the big benefit of MRI is that it's very, very sensitive for detecting breast cancer, and it does not involve any radiation. But it does have some limitations. It can be really difficult for patients to tolerate MRI exams because, especially if they have claustrophobia, because they have to kind of slide into that little donut hole, and that can be tough. Most MRI exams take somewhere between 10 and 30 minutes to complete. The abbreviated MRI is usually less than 10 minutes, but even that can be difficult for some women. We also have to put in an intravenous line, an IV line, to administer the contrast material that lets us find the cancers. And MRIs are relatively expensive, so even if your insurance does cover MRI, there's often some cost sharing with your deductible or your copay. And it also has a fairly high false positive rate, although that's come down over the years as we get more and more used to what kind of normal MRIs look like. And then most women who have a pacemaker cannot undergo an MRI examination. So those are kind of the most standard methods of additional screening. And I'm going to move on to the kind of more sort of newer methods for supplemental screening for dense breast tissue. So this is a technology called molecular breast imaging, and this is what the machine looks like that acquires the images. And you might notice that it looks a lot like a mammogram machine, where it has the kind of paddles that compress your breast between it. And this is a nuclear medicine examination. It's a type of imaging that allows us to see functional and metabolic information in the breast. You're in a similar position to what you are when you get a mammogram, but there's less compression than what you would get with a regular mammogram. You're injected with something that we call a radio tracer. So again, you get an intravenous line and get injected with this radio tracer, which is the teeny amount of radiation that circulates through your body to go to the so that we can see the areas of cancer, and it leaves your body shortly after the exam. And it's important to recognize that the radiation dose to your breast from this type of exam is lower than the radiation dose from a mammogram, but the body radiation dose to the rest of your body is a little bit higher because that radio tracer kind of circulates through your body as it's making its way to the cancers. And this is about a 20 to 40 minute examination, so a little bit longer than, for example, a mammogram. But the additional cancer detection rate with molecular breast imaging is about 8 to 9 per 1,000 women screened. So almost as high as MRI and substantially higher than ultrasound or 3D mammograms. And right now there's an ongoing multi-center trial looking at molecular breast imaging as a supplemental screening method in women who have dense breast tissue, and that's called the Density Matters trial. So here's what those images look like. This was a 48-year-old woman who presented for supplemental screening after her mammogram. And the two images on the left side of the screen are her two standard mammogram images of her left breast. And then on the right-hand side of the screen, those are the corresponding molecular breast imaging images. And what I hope you can see is there's a white dot kind of in the center of the breast on each of these images. And that turned out to be an invasive cancer that this patient had that was not visible on her mammogram. So you can see that, again, dense breast tissue does not limit interpretation of molecular breast imaging. So some of the benefits are that it's more sensitive than ultrasound, less expensive than MRI. It looks like it has a sort of similar sensitivity, maybe slightly less than MRI, but definitely higher than ultrasound. And it's relatively low cost compared to especially an MRI. Limitations are that it does involve radiation. Most of the data we have on this method are limited and from single centers, like single academic medical centers doing studies, and this type of imaging is not currently widely available. There are only about 30 facilities around the country that are using this technology right now. So the last technology we're going to talk about is called contrast-enhanced mammograms. So contrast-enhanced mammograms from the patient perspective, again, is very similar, just like a regular mammogram where we have the paddle and compress your breast in our standard 2 views for each breast. but there's a software upgrade and attachment to the mammogram machine. And you will get, again for this one, an intravenous line where we inject the contrast material. Most of the research with this technology has been done in women who have a known breast cancer, but from the limited data we have in women who have dense breast tissue and no known breast cancer, it looks like we're detecting about 10 cancers per 1,000 women screened. So again, almost as high as MRI, similar to the molecular breast imaging, and definitely higher than the ultrasound and 3D mammogram. It does have a slightly increased radiation dose compared to regular 2D or 3D mammograms, but this is still well within acceptable limits. And there's also an ongoing multi-center trial on contrast-enhanced mammography looking at women who have dense breast tissue and are opting for supplemental screening. And this trial is called the CMIS trial, and it is currently recruiting patients if anybody is interested. So this is what the contrast-enhanced mammogram images look like. So what we have here, if you can see my mouse, is on the very left side of the screen is a left CC that stands for craniocaudal view. So one of our standard mammogram views, and you can see that this patient has very dense breast tissue. And then next to this, what we see is the corresponding contrast enhanced mammogram image where we can see a little enhancing dot right there in the middle of the breast that was totally masked by the dense breast tissue, but comes out very nicely. The contrast enhanced mammogram, again, is not limited by the dense breast tissue. And then we have the corresponding left medial lateral oblique view, which is our other standard mammogram view we get of the left breast. And again, here's that dot, which is localizing to the upper part of the breast. And again, is totally masked by the dense breast tissue on the regular mammogram, but you can see it really well on the contrast enhanced mammogram. So benefits of this technology are that it can be incorporated into existing machines that are already kind of all over the country while women get their routine mammogram screenings. And it looks like it has really high sensitivity, again, similar to MRI. It's relatively low cost, especially, again, compared to MRI, and it might be better tolerated by patients than MRI because it doesn't involve going into that little donut hole. And so for patients with claustrophobia especially, that would be a better option for them. But again, some limitations. It involves the use of intravenous contrast, again, so you have to get an IV line placed, and also contrast monitoring. So we have to have a nurse or doctor around when you're getting this examination because there's a very small risk of contrast reaction. And like I mentioned, it's not quite as well researched as a screening tool as some of the other methods are. And again, it does involve some radiation dose to the breast. So after all that, you're probably left wondering which one of these methods should I choose or what do I need to do next? And my advice to you is that you need to know first and foremost what is your personal risk level of developing breast cancer. Because again, if you fall into that high risk category, which we define as greater than 20% lifetime risk of breast cancer, then you really should be undergoing screening with MRI, additional screening on top of mammography with MRI. Then the next question is, what is your breast density? If you do not have dense breast tissue and you are not at high risk of breast cancer, then mammograms are probably enough for you. But if you do have dense breast tissue and you are at average or intermediate risk for breast cancer, then that's really where you might want to start thinking about doing one of these supplemental screening methods like ultrasound or MRI or molecular breast imaging or contrast enhanced mammography. And what this is largely going to depend on is what's available in your area. So most institutions will offer one thing or another. So you may have access to supplemental screening with ultrasound. Again, that's the most common type of additional screening that people undergo, or you may have access to abbreviated MRI, for example. So it really depends on what's offered at the different facilities that do medical imaging in your area. So in conclusion, dense breast tissue makes it harder to find cancers on mammograms. Dense breast tissue increases your risk of breast cancer. All women need to undergo breast cancer risk assessment by the age of 25. 3D mammograms are great, but they're only a little bit better than 2D mammograms for women with dense breast tissue, and dense breast tissue still limits the accuracy of the 3D mammogram. Ultrasound is the most common used method for supplemental screening at women who are at low or intermediate risk for breast cancer, and it is not as sensitive as some of those other methods that we talk about. So, for example, MRI, which again is preferred for any woman who's at high risk for breast cancer, regardless of her breast density. And we have growing evidence now and growing recommendations that it's helpful in all women with dense breast tissue. Molecular breast imaging is also another supplemental screening method that detects more cancers than some other methods. It's relatively low cost, but we still have limited data. And contrast-enhanced mammograms also look like they're going to be a great method for detecting supplemental cancers, but they are relatively low cost, but again, we have limited data on them right now. So everybody should stay tuned for more data and recommendations coming out, specifically with regards to MRI in women at average to intermediate risk with dense breast tissue, as well as molecular breast imaging and contrast-enhanced mammograms. Thank you so much for your attention, and I look forward to taking some questions.
Wonderful. Well, thank you so much, Dr. Dibble. And so to you, our audience, what I'm going to do really quickly is we're going to run one quick poll, but I definitely urge you to stay on because we have the Q&A portion coming up next where you can submit your questions, remember, in the right to your panel, and we will ask them to Dr. Dibble. So definitely stick around. So I'm going to launch one quick poll for you. You should see it up on your screen in front of you. It says, my biggest question about breast density is, and then you have different options to choose from. So I'm going to give you, our audience, a moment to log your answer very quickly and just go through and type or click on whichever one resonates with you the most. And then at the end, what I'll do is I'll go ahead and show the results. And like I said, right after this, we're going into the Q&A portion. So we've already received a lot of really wonderful questions from you, our audience. So go ahead and stick around, like I said, because we've got a great section coming up just for you. Alrighty, so I'm going to give everyone just one more moment. Okay, so now what I'm going to do is I'm going to close the poll in just a moment and then launch the answers so even you, our audience, will be able to see them. Alrighty, so here we go. All right, I'm going to share that. So the biggest question about breast density is, what breast cancer screenings are best? Okay, now into the Q&A portion. So, Dr. Dibble, the first question is it possible to reduce breast density through diet? And if so, what is that diet? And does caffeine and red meat play a role?
That's a great question. And I would say in general, no. We can sometimes see if patients gain or lose a lot of weight, that the relative fatty tissue to fibroglandular dense breast tissue ratio in their breasts will change. So if you lose weight, which would be a good thing to reduce your risk of breast cancer in general, a lower or normal body mass index would decrease your risk of breast cancer, but that would increase your breast density sometimes on the mammogram. So there's not much you can do to control your breast density. It kind of is what it is. And I noticed a lot of people were wondering how it changes with age. And I'm going to reiterate that breast density does tend to decrease as you get older, and especially after you go through menopause. So, but that being said, there are plenty of women in the postmenopausal phase of their life who have dense breast tissue. And it sort of just is personal to you. And again, it's not going to bump you up, you know, from a completely average risk of developing breast cancer to a super, super high risk. But it may, you know, in those risk models may increase your risk very slightly by, say, 1% or 2%.
Okay, that's good to know. And on that note of obviously the topic of breast density, you mentioned that a trial, the Density Matters trial. So how can our audience explore the possibility of being a part of the Density Matters trial?
That's a good question. So yeah, there are a couple of trials. The Density Matters trials and the CMIST trial are two trials, one looking at molecular breast imaging and one looking at contrast-enhanced mammograms. And if you Google them, it'll help you find a lot of information on those trials. But specifically the the Density Matters trial is being run out of the Mayo Clinic, and they have some information there on the website, and the NIH also has, both of these are funded trials, so there's information that you can find on NIH websites as well about who to contact for additional information. And sites are kind of still entering the trial, so it's possible that if a site near you isn't enrolling, they may be in the future.
Wonderful. That's good to know. And this next question jumps into AI. So, how is artificial intelligence being used in breast screenings, and how does it affect the screening's accuracy?
That is a great question, another kind of hot topic in radiology. And the reality is most of us in breast imaging are not really using AI yet for clinical purposes. There are a lot of AI programs out there. There are somewhere in the range of 100 FDA approved AI, artificial intelligence programs for assisting radiologists in interpreting medical imaging in general. There are some radiologists that are using AI, but nobody yet is using it, or I say yet, I don't know if this will ever happen. Nobody is using it to kind of replace the radiologist or the kind of expert interpretation of your mammogram. So you don't need to worry about, a machine interpreting your mammogram and you're not getting a doctor looking at it or something like that. But there's a lot of interest because some of these AI programs seem to be kind of as accurate or even able to add to the accuracy of a radiologist. So we may in the future do something like have the radiologist look at it and then have a kind of a second read by the AI.
Let's switch to this one. How is breast density affected by hormone therapy, such as menopausal hormone therapy?
That's another great question. And hormone therapy can increase breast density. So kind of for the similar reasons that I mentioned, that after women go through menopause, they tend to have, their breast tissue tends to decrease. We also know that breast density can increase when patients are on hormone replacement therapy.
Ah, okay, great. And so this next one asks, if someone needs a diagnostic mammogram, do they need it every time they're screened?
No, that's a great question. So for a little background for people, we have basically two types of mammograms that we do. The screening mammogram, which is for everybody starting at the age of 40 every year, unless they have other risk factors. And that is for people who have no symptoms at all, no problems, just coming in for their routine screening. And contrast that with a diagnostic mammogram, which is when someone has some particular issue with their breast, whether that be that they had a recent history of breast cancer, say 6 months ago or a year ago, and we're kind of keeping a close eye on things, or they got called back for additional imaging after their screening mammogram, where we want to kind of get some more pictures. And for the diagnostic mammogram, that's going to get read in kind of in real time by the radiologist compared to the screening mammogram, which usually we do something called batch reading, where we read, you see the technologist get your mammogram, you go home, and then later that day or the next day, usually the radiologist will interpret your mammogram and you'll get your result. So the question was whether people need to continue undergoing a diagnostic mammogram if they have had one, and it depends on the reason why they had a diagnostic mammogram. So if you got called back for extra views from your screening mammogram and the radiologist tells you everything is completely fine, it was just some overlapping breast tissue that looked a little bit different this year, then you typically would go back to your regular screening mammogram. So you'd come back a year later and just get another regular screening mammogram. But if, say, the radiologist finds something that they think is almost certainly not cancer, but they just want to keep an eye on it, and they ask you to come back in 6 months for another mammogram, that would be a diagnostic mammogram, because there's something that is happening that you're following, so you're not in the kind of going back to the routine screening group. So it really does depend on what the reason was for your diagnostic mammogram.
Okay, and this next question touches on the topic that you brought up about genetic testing. So, as for genetic testing for the BRCA1 and 2, if a woman is tested and she's negative, but her mother had early breast cancer, does the woman's daughter need to also have genetic testing? In other words, can genetic risk skip a generation?
No. So the question that I would have was, did the person's mother have BRCA1 testing? So if the patient's mother um, did have a BRCA gene mutation and the patient did not, then that patient, it would not be considered to be high risk because of the family history. But if the patient's mother was not tested and the patient was tested and only tested for the BRCA gene, then there are those 9 other genes we talked about that the patient could also might also have, as well as, those are only the genes that we know about right now. So if you have a strong family history, but everyone in your family tests negative for one of those genes, you still are at an increased risk because there is something, maybe there's a gene that we haven't identified yet, or there's something that is causing family members of yours to have an increased risk for breast cancer. So to answer that question, it depends on whether the mother was tested. And no, it would not skip a generation. So if your grandmother had a BRCA gene mutation, but you did not inherit that gene mutation, then your daughter is not going to have that gene mutation unless she got it from the other side of the family.
Okay, thanks for shedding some light on that. So this next question asks if MRI isn't better at detecting breast cancers, why do we still use mammograms at all for women with dense breasts? So I'll ask that again. If MRI is better at detecting breast cancers, why do we still use mammograms?
So that is a very good question. And MRI does not detect every single breast cancer that a mammogram does. And in addition, mammogram is what we have decades of data on, proving to us and hopefully proving to all of you that they decrease what we call morbidity and mortality from breast cancer. So patients are diagnosed early and they're diagnosed at a lower stage, which means that their breast cancers are more treatable and more curable compared to if they don't undergo a screening mammogram. So we don't have that kind of robust data for MRI screening, and certainly not in the dense breast population. It's possible that things could change in the future, but for example, something like calcifications show up very well in a mammogram. We don't see that on an MRI. It tends to be one of the earliest signs of breast cancer. And sometimes we can see an abnormality on the MRI, but not always. So we definitely typically recommend people still undergo mammogram screening.
Okay, and then you also mentioned the breast cancer risk tool in your presentation. Would you mind letting everyone know the website for that again?
So the tool that I mentioned was the Tyrer-Cuzick risk assessment model, and IBIS is the beginning part of the website that I have used to do this with patients, and I have done it for myself. So I think that's a good one for people to check out if they're interested in doing that calculation.
Okay, thank you so much. And our last question is there room for different interpretations or opinions among healthcare providers when deciding if you have dense breasts?
That's another good question, and the answer is by and large, no. It can be a little bit subjective, and there are some different software programs out there that give kind of an objective measurement of your breast tissue, but the way that we interpret it and what our guidelines say to do is that we do it subjectively, and the reason for that is sometimes patients may have, or people on their mammogram may have, like a patch of very, very dense breast tissue in one area, and so we know that we could be missing something in that area. So even if all the rest of their breast tissue looks not dense or fatty, we still know that that's a limited mammogram. So that's an example of why we tend to do this more subjectively, but that, again, like I mentioned, breast density is on a continuum. So there may be one year where you're like kind of on the border of dense and not dense, and then maybe you come back the next year and you very clearly fall into one or the other category. But there is a little bit of subjectivity there. So I would say yes, but by and large, it's pretty It's pretty standard among us. There are a lot of studies showing that there's inter-reader reliability on deciding what breast tissue someone has.
Oh, very, very good to know. So we want to thank Dr. Dibble for answering you, our guests' questions, including, is it possible to reduce breast density through diet? Can genetic risk skip a generation? And how is breast density affected by hormone therapy? So as we bring our webinar to a close, again, we want to thank Dr. Dibble for such an enlightening and informative presentation and answers to your questions. And to you, our viewers, thank you for joining us today. We hope that you learned something new to help you make informed decisions about your health and well-being in consultation with your physician or care team. You'll find more information about this condition at our website at webmd.com/breast-cancer. There's a wealth of tools, resources, and support for you to access any time of the day. And if you're signed up for the WebMD Women's Health newsletter, you'll get information regarding our upcoming webinars on this topic. If you're not, you can get signed up today at webmd.com/newsletters. And you can also view our full library of on-demand and upcoming webinars on many topics at webmd.com/webinars. So after today's webinar, you receive a survey along with a recording. Please take a few minutes to complete that survey as your feedback is important to us. It'll help us plan and improve future webinars. So again, thank you to our viewers, and Dr. Dibble, thank you again so much.
Thank you so much for allowing me to talk to you all.
Wonderful. We hope you have a great rest of the day. Until next time.